guest speaker, Mr. Raymond Fong, and he's very experienced speech therapist at the QM Hospital. Some of you may have worked with Mr. Fong before, probably not, depending on which clinic you went to for your clinical placement. So it's a great pleasure to have him to share with us the swallowing and also speech management in patients with tracheostomy. So let's give a hand to Mr. Fong.
Okay, so thank you, Estella. It's my pleasure to be coming back and just give a short talk on this topic, speech and swallowing in patients with tracheostomy. I understand that all of you are currently having placements in HA, right? Are you happy with that? I don't see who is having his the placement in Queen Mary. So, have you seen a patient? Did Amy take you to a patient who has a tracheostomy tube? Have you seen one? You observed one. Okay. How about other students? Have you seen one? Have you seen a patient with a tracheostomy? No. Some yes. Very few. So for those who have seen one, did you perform a swallowing speech assessment? No. So what did you do? Just observation. Observe the patient using a speakerphone, and then you were being questioned. Were you intimidated when you went to see the patient with tracheostomy tube? Definitely. Okay. I don't know. Some of the supervisors, or even when I had my placement, I was told that if you do well on this case, or if you do well on these sessions, then I'm going to take you to see a patient with a tracheostomy tube. As if it's like a reward or something. I don't know. I mean, it's not really a reward, right? Okay, it's a little bit intimidating. Some may feel that whenever they see a patient who has a tracheostomy tube, they get scared, and understandably, right? Because a lot of these patients are critically ill. They have all kinds of medical problems, surgical problems that leads to the presence of a tracheostomy tube. Okay, so these are the learning outcomes that I hope that you could achieve. I don't know. Some of you may be having placements in convalescent hospitals. Right? Not all of you, I'm sure, that are having your placements in acute hospitals, right? Which one of you are having placements in acute hospitals? Quite a lot. Convalescents? Only convalescent hospital or rehab hospital? None of you? Okay, a little bit. Okay. Well, actually, these kind of patients, they exist in both hospitals. Okay, but I'm sure a lot more in acute hospitals as well. So learning outcomes are here. I guess the most important thing is that you will not be intimidated, okay, by the tracheostomy tube itself or your supervisor when you see a patient with a tracheostomy tube later on, okay? And that is very important, and I'm sure I'm not going to be able to cover everything that has to be covered on this topic in the next 2 hours or so, okay? But I did bring along a lot of toys. Okay, so I have all kinds of tubes here that you can get your hands on, and some syringes, and my good friend Tom. Okay, so Tom is here. He's going to be tracheostomized, and you can have your hands on him. Okay, so first thing first, what is a tracheostomy? For those who have seen one, what is a tracheostomy? In your own words, can you describe that? You've seen one in QM. How would you describe that? Sorry, you know what? Okay, so it goes into the trachea. Obviously, the name implies tracheostomy. It's an opening at the trachea. Okay, and the most important thing for a tracheostomy is to allow a patient to breathe. Okay, that is the utmost important thing. Okay, speech, swallowing, it's going to be affected by this tube. Okay, but the utmost important thing for this tracheostomy or the presence of the tracheostomy tube, it's actually an artificial opening, so the patient is not going to be born with a open stoma. The patient is going to be undergoing a surgery to create an artificial opening in trachea, and the goal of it is to establish an airway through the neck. Okay, and it can be done either with a horizontal incision or a vertical incision. Where exactly is the site of the tracheostomy then? Where exactly it is? Can you point to your neck? Anyone had a tracheostomy done before? Probably not, right? Okay, but it's not that uncommon, I can assure you. Okay, where is the tracheostomy? If it has to be done on you, where do you think it's going to be at? Right there. Okay, where is it? Not here, right? No. Okay, so where? Not every earlobes. Where? Lower than the what? Lower than the thyroid. Not specific enough, right? Okay, you're going to get killed by your supervisor if you say lower than your thyroid. A lot of things are lower than your thyroid, right? The cricoid is lower than your thyroid. So where? Right there. Okay. Not just lower than your thyroid, but lower than your cricoid. Okay, so it's not going to be somewhere between where your laryngeal excursion, your laryngeal elevation is going to be at. It's going to be much lower. Okay. Have you seen the TVB drama where they create the cricothyroidotomy? Have you seen that TVB drama? It's pretty true. 嗰個唞唔到氣嗰個咧，跟住咧佢揾啲原子咧插咗落去，其實幫佢唞氣咧。有冇睇過啊？嗰套唔知咩，我唔記得咗叫咩。花世代。Really? Okay. I should go and search for it. Okay. So actually in a lot of TV drama that on topic of emergency medicine, they would do that, right? They put in the pen, or if your friend suddenly has a problem breathing and you want to play hero, where are you going to start? Where are you going to stick your pen or to create that opening? That opening is going to be between the cricoid and the thyroid, okay? And that surgery, or not surgery, that procedure would be called a cricothyroidotomy, okay? But that is a temporary, in very emergency condition that they would do that, okay? So create that small opening with anything, with a chopstick or with a pen or whatsoever, whatever you can find in the field, they would create that opening between, and the membrane between your cricoid and your thyroid, okay? But this is not tracheostomy. Tracheostomy, the patient usually has to be pushed into the operation theater and create an opening. And the opening is usually, as you can see from this diagram, usually between the third and the fourth ring of the trachea. Okay, sometimes a little bit higher, sometimes a little bit lower, depending on the patient. Okay, so as I said, either a horizontal or a vertical incision. What we like to see is a horizontal incision because it would promote healing, and it would affect the patient less when the tracheostomy is healing. Okay, so bear in mind this. Obviously, one of the students said that it's below the thyroid, so it's very important to know that it's below the vocal folds. Okay, it's not above the vocal folds. Okay, so don't get that wrong, because that's very important when we talk about cuff fenestration. Okay, all these things. And as I said, it's actually more common than you think. Okay, statistics from the U.S. in 1996, 64,000. Okay, and now it's well over 100,000. And in Hong Kong, I just took a quick glance at our caseload, and we have about 2% of our cases. Okay, so 2% of our cases as inpatients who has a tracheostomy tube. Okay, but that's just Queen Mary. Okay, other hospitals may be a little bit different. And even for outpatients, they sometimes get discharged with a tube, inside tube, and they can still be discharged. Okay, so this is more common than you think, and it's commonly seen in patients who has acute respiratory problem. Very common if you go to, if your supervisors bring you to neurosurgery wards, okay, or neurology wards. Some of these patients, when they have profound neurological damage, they lose the ability to breathe by themselves, then they will get a tracheostomy. Okay, and obviously if the patient has a head neck tumor or ENT problem that impinges the airway, causing upper airway obstruction, then they would need the tracheostomy tube as well. So who would have a permanent tracheostomy? Now, obviously, it's those that are usually because you can't have a permanent respiratory problem, right? You're probably going to die if you have a chronic one. But if you have a bilateral vocal cord palsy in an adducted position who is not recovering, then your airway is forever going to be narrow. And how do you breathe? Obviously through the artificial airway. So the tracheostomy tube has to stay there. Okay, so that's what tracheostomy is. And the indication, just keep in mind that whenever an artificial airway is needed, okay, whether the patient has to be assisted to breathe, so if the patient has to be on ventilator for a long time, the patient might need a tracheostomy tube, okay? Not that when they get ventilated, not that whenever a patient has is ventilator dependent, they would need a tracheostomy. No, okay? So what tube would they get if they are just, like for example, if you suddenly collapse and then you get rolled into Queen Mary? Hopefully not. But if you do, and they have to intubate you, what tube are you going to get? You're going to be on a ventilator, you're going to be hooked up to a ventilator, but they're not going to do a tracheostomy on you as soon as you get hooked up. So what tube would that be? Not a tracheostomy tube, what tube would that be? For patients on a ventilator, not with a tracheostomy tube.啲 terms 都會出現嘅，咩 tube， 擺條咩 tube 先，放喺頭度嘅。Okay, maybe we won't see these patients. Okay, you won't get called to see these patients a lot, but sometimes we still do. They call it an ET tube, right? An endotracheal tube. Okay, so ET tube is something different from a tracheostomy tube. Okay, ET tube is just that when you get intubated through the mouth, usually, sometimes through the nose as well. So the artificial airway that's not creating an opening at the trachea, we call it ET tube. Okay, and you would read this in your clinical notes as well, because they would write down, how many days was the patient on an ET tube, and how many days was the patient on a tracheostomy tube. Why is that important? Why is that important? If you have a patient who has been on an ET tube for a prolonged period of time, say 7 to 10 days, as compared to someone who hasn't had one, would you predict that there would be any difference in their airway? 會有咩唔同啊？條 ET tube 你諗下佢會由邊度擺到邊度啊？佢要擺 on ventilator， 冇錯喺個口度啦，跟住咧 it goes all the way down to it passes through the vocal folds, it goes into the airway, right? So it's about 20 something cm long. Okay, it's a long tube. If the vocal folds get compressed by that, okay, hopefully not, but if it does, what's going to happen to the vocal folds? A lot of bad things are going to happen. Okay, they could end up with a granuloma if the patient is struggling a lot. Vocal fold granulomas, edema, all these things could happen. So for patients who have had an ET tube for a very, very long time, usually won't be over 10 days, okay? Because if the patient has a tube for over 10 days, probably they would do a tracheostomy. Okay, so that's why we jump from an ET tube to a tracheostomy, because prolonged intubation could lead to bad things in the airway. Okay, so respiration, if an artificial airway, of course, that's one of the functions, and another function is suctioning. Okay, or we call toileting. Toileting of the airway. If the airway, if the trachea has a lot of secretions, a lot of saliva aspirating, and the patient cannot cough it out, let alone the patient being unconscious, or the patient has very, very poor coughing effort, then the tracheostomy tube can serve as another function, which is for toileting. Okay, so suctioning. And the common indications for tracheostomy would be, as listed on the right-hand side, airway obstruction, as I said, those with panic, tumors, ENT problems. So if you have a supraglottic Okay, so anything that's above the vocal fold or subglottic, edema, tumor, inflammation. Okay, actually we've seen a patient who had an emergency tracheostomy done. You wouldn't know why the cause is. Okay, the patient was well before. Okay, and then suddenly admitted because of neck swelling. Okay, and these things happen, and the doctors asked the patient why. The patient said that it so happens that he ingested a fish bone. Okay, and it got lodged in his neck. So be really, really careful, because fish bone lodging in your pharyngeal wall could lead to very, very severe inflammation, and the patient eventually had a tracheostomy done. Okay, and we have that's a patient that we saw. So it's not just tumor, it's not just edema. Okay, inflammation could happen as well. And in pediatrics, if they have a congenital anomaly of the airway, they could also end up with a tracheostomy very, very early on. Okay, what are the patients that you would think about having a very narrow airway or a congenital problem? What syndrome or what condition? Narrow airway, that they may need a tracheostomy.有啲咩仔係個透氣成個 airway 都好窄㗎？仔啫喎，唔係大人嚟㗎。唔使睇我啲 notes，我啲 notes 冇講嘅。有咩仔？有種 syndrome starts with P， 好似好型咁啊個名。P 咩啊？但係差唔多咩啊？Pierre 啱啦 ，Pierre Robin 係咪？係啦，我冇讀過 Pierre Robin 啦，係好笑嘅。Pierre Robin syndrome，okay? What are the characteristics of these patients, of these children? Pierre Robin 係點㗎？唔知㗎，即係 Google 下啦 ，OK？Pierre Robin 係點㗎？通常佢哋有冇人做？譬如有啲譬如你去過，譬如 SCC 有啲都會有嘅，係嘛？你 Google 下，你見到佢哋嘅 image 通常係點㗎？Pierre Robin Pierre Robin 係點㗎 ？Facial abnormality 係有咩 facial abnormality 咧？你睇佢個下巴係點啊？冇錯啦 ，small jaw 啦，係咪啊 ？retracted chin 啦，係咪？咁即係話咧，佢 relatively the patient has a large tongue, okay, a very, very small mandible, and in severe cases they may have a problem with breathing as well. Okay, a small portion of these children end up with a tracheostomy tube very, very early on. Okay, and apart from that, some with laryngomalacia or tracheomalacia. Okay, say very, very floppy larynx. Okay, and trachea they would need one as well. Okay, and bilateral vocal fold paralysis, as I mentioned, prolonged ventilation, copious secretions, or a very uncommon one. That's a little bit wrong. I should put obstructive sleep apnea. Okay， 如果覺得自己鼻鼾好勁嘅話，你都可以考慮下去做個 trachea。咁咧，因為咁就可以 definitively 解決咗你個鼻鼾個問題啦，係咪？咁呢個鼻鼾就係因為唞氣嘅時候好多嘢阻住啊嘛，好多嘢阻住就有聲啦，係咪？咁有聲嘅時候，如果你喺度開個 trachea 嘅話，咁咪冇嘢阻住咯，係咪？咁所以如果你有鼻鼾，你可以考慮下去開個 trachea。Okay, so you may ask, so I was asked to go and see a patient with tracheostomy tube with my supervisor, and my supervisor never told me why the patient needs a tracheostomy. So you never know the indication. So why is it so important to know the indication? This is a very, very problematic thing, a very common mistake that are made by clinicians. Okay, I get colleagues coming to us, just for discussion of cases, okay? And they would come to me or my colleague here, just have a discussion. And then they would say, we saw a patient where have a tracheostomy and the performance of speech and swallowing is like this, blah, 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 okay? The first question that I would ask is, why did the patient have the tracheostomy? Okay, the indication of the tracheostomy is very, very important. Okay, if you don't know, ask. Okay, find it from the progress notes. Ask your supervisor. Ask your colleagues. Okay, ask the nurse. Ask the doctor when if you work in a hospital later. Okay, because the indication of the tracheostomy is crucial to your management. Okay, think about it. If the patient has a tracheostomy because the patient has copious secretions, as compared to a patient who has a tracheostomy because he has bilateral corporal paralysis, is it going to make your management different later on? Okay, it is definitely going to be different. Okay, just take these two things for example. If a patient has copious secretions, then would you expect the patient's speech or swallowing to be really, really bad? Which of these two things would be likely to be worse? A lot of secretions. It would mean that swallowing is bad, right? Okay. Then how about if a patient has a bilateral corporal paralysis? What would you expect the patient's speech to be like? Not too bad, because it's adducted, right? Okay. But can you try and occlude the outlet of the tracheostomy tube? No, because the patient is going to die. Okay, so knowing the indications is very important, and I hear a lot of excuses. 知做乜啫？係咪先？咁你做完跟住你咪又做 blue dye， 係咪先 ？I hear this all the time。你跟住咪又俾個 swing mark 佢 ？No, that's not true. Okay, we don't always do the same thing for patients with tracheostomy tube. It's not clearly documented. Okay, these are excuses that I hear. You need to know because, as I said, it's the foundation. Due to these few things, the pre-tracheostomy status. Okay, so how the patient was before he or she had the tracheostomy tube put in. It's crucial to how patients do after tracheostomy. Okay, and the indication of trach is, as I said, is going to affect the speech and swallowing function, and it's also going to let you predict. Okay. To predict whether the patient is going to need the tracheostomy for a prolonged period of time or the patient can be weaned off very, very quickly. Okay, so the likelihood of tracheostomy tube dependence. And our key role, obviously, in these kind of patients is, apart from doing assessment, is actually counseling. Okay, I have had patients coming to us and I had to teach the patient to change the tracheostomy tube in the cannula to clean how it should be cleaned. And it obviously is not our role, it's the nurse's role, but because nobody tells the patient about these things. So one of our roles, except for, apart from assessment, is also counseling. Okay, so knowing the tracheostomy, knowing the indications, they're both important. Okay, so always ask yourself, okay, before you proceed to anything. Okay, don't touch the patient yet if you don't know why the patient had or have a tracheostomy tube. Okay, and the reasons are usually these ones. Okay, always do that. Okay, so any questions on the basics of tracheostomy? Okay. Now you might think that, oh, I'm not going to work in a hospital, I'm not going to probably not get hired by HA or whatsoever, but the good news, HA is probably going to cut half point嘅頭俾你哋，我聽講 good news。HA 都應該有啲錢嘅嚟緊呢一兩年係啦，所以都會有少少 opening 嘅，咁所以咧都緊要啦呢啲嘢係咪？同埋 even if your heart is not in HA, after these torturing sessions by your supervisors, these people still exist in the community. Okay, in elderly homes, even in special schools. Okay, it's getting much more common. So definitely need to know, even though you don't plan to work in a hospital. Okay, and And another thing that I want to just bring up before we go on to the next section is when you study about dysarthria, which book are you going to read? 我年代嘅有冇幾大分別先 ？dysarthria 係咩啊？都係特別㗎，係咪？係啦，咁啊睇嘅都睇唔明啦。但係都係要睇啦嚇。我到而家做緊嘢，我都仲繼續睇啦。swallowing 咧，係咩啊？包括文啦，係啊，都係嗰本啦，係咪？人都唔喺度，都仲係有睇佢本書啦。仲有其他嘅，其實係啦，唔好淨係睇 document 啦，即係都 side track 一下啦。其實有本有冇聽過一本叫做Principles of Deglutition 啊？完全冇聽過啦，係啦，呢本書係我覺得即係the second Bible 啦 for swallowing。Principles of Deglutition 係你哋聽過 Tracheostomy exercise 啦，係咪？咁就係呢一個 Tracheostomy 寫嘅，呢本書仲難啲添嘅，不過咧好琴嘅人寫好好嘅。OK，so whenever you run into a case with dysarthria or apraxia, then you read them. Okay? Whenever you have a case of dysphagia, you want to look for references, you go to a Jerry Logerman or the book that I just mentioned, Principles of Deglutition. How about tracheostomy? 有冇聽過本書係即係講 trachea 講得好好嘅 Bible 嚟嘅咁樣？你睇下我後邊個 key reference 咧，我 even 即係我都冇一本書咧係可以講 trachea 咧講得好深入嘅。點解咧？因為 trachea 呢樣嘢咧，其實係 ever evolving 嘅即係有唔同嘅 tube， 有唔同嘅 accessories 咁呢啲其實已經即係佢一路變嘅時候咧，你一得本書係冇用嘅。咁所以咧 ，whenever you want to look deeper into or read deeper or into tracheostomy, there are two things that you should look up. One is clinical guidelines. Okay? Not just in speech therapy, but clinical guidelines for tracheostomy management. Because to manage a patient with tracheostomy, you're not going to be the only one. Okay? You have to work with nurses, other multidisciplinary approach. And so clinical guidelines would be very important. And another thing is go to the websites of the companies that make these tubes. Okay? They give you very, very important information. Okay? And there are literally tens and thousands of tracheostomy tubes in the world. Okay? I don't think anyone would know every tube that exists. Okay? We have seen patients with very, very bizarre tracheostomy tubes. Okay? Some coming from mainland China, in shapes that we've never seen before, in conditions that we've never seen before. But it's important because the nature or the properties of the tube itself is important to how you manage your cases. Okay, so as you can see here, we have different brands. The most common one. 頭先又話有見過 Trachea 嘅同學啦，見過或者你個 supervisor 或者你有冇去揾過佢係屬於咩牌子嘅 Trachea？冇啦，係咪啊 ？Shiny 啊，係咪有人講過Shiny 咗牌子？ Okay, so we have common ones. We have Portex. Okay, Portex is the one on the right hand side. Usually it's blue in color. Okay, so whenever you see a blue tracheostomy, most likely it's a Portex tube. And the ones that are used in Hong Kong for Portex, it's usually single cannula. Okay, I'm going to go deeper into what are these terms later on. Okay, Bivona is another tube that we don't use very often because it's quite expensive and it's not commonly used in Hong Kong. Shiley is a very, very common brand. Okay, Shiley tracheostomy tube. I don't know why everybody calls this brand Shirley. Okay, it's not Shirley, it's Shiley. Okay, Shiley, but if your supervisor says Shirley, it's Shirley. Traco. Okay, Traco is another brand. All kinds of tubes. Okay, the materials that make up these tubes can be either plastics or usually plastics or silicons or metal. Okay, plastics. You can feel it later on when I pass it around. It's obviously less, it's softer, but it's also less durable. Okay, than metal ones. We don't see a lot of metal tracheostomy tubes. Okay, because it's just not commonly used in Hong Kong, but in countries like the US, it's quite common. But usually for long-term use, and mostly used in adults. Okay, so the terms here, okay, those are the brand. So what terms would we use to describe different tubes? One is cannula. Okay, some tubes are single cannula. So, for example, the ones on your right, or the one in my left hand right now, that's a single cannula. Okay, I got that. Nothing can be pulled out, nothing can be put in. Okay, so single cannula tracheostomy tube, it's very easily to be blocked by sputum, as you can imagine. Sputum coming up from trachea, gets stuck there, you can't suction it out, and it's blocked. And what do you have to do with the tube? You have to replace it, right? Okay, so replace the whole tube with another one. So it cannot just be exchanged easily. Okay, the whole tube has to be exchanged. That's a single cannula, and it's usually used for patients, who just had the tracheostomy tube put in. Okay, so if you have the surgery of tracheostomy, you're most likely going to end up with this tube. Okay, so single cannula. I'm going to pass it around. All these tubes, just feel free to touch it. Okay, it's not used. It hasn't been used by patients, so don't worry. Double cannula is another type that you have this is a double cannula tube, so you can see that there's an inner cannula that can be taken out, and this is the outer cannula. Okay, and there are many, many different types of cannulas. Okay, the inner cannula can be changed by the patient himself or herself, and usually it's for the purpose of hygiene. Okay, so if you have this tube, in you, and it's get blocked by sputum, if you have that tube, you can't easily get it out. But if you have this, and then the sputum is right there, you can just take it out, rinse it in water, and then put a new one in. Okay, so it's mostly for hygienic purposes. But the bad thing, so then you might ask, why don't everyone get a double cannula tube? It's more hygienic, it's better. The bad thing is that if you have a fenestration, which I'm going to explain later on, if you have a fenestration and you change this inner tube all the time, you might develop granuloma right here. Okay, so granuloma is because you take it out, put it in, and the tracheal wall gets rubbed against this tube itself. Okay, so you might develop granulomas. Okay, 會生肉芽出嚟，咁好麻煩。如果生肉芽咧，it needs to be removed or cauterized by an ENT surgeon. Okay, and it could sometimes the big ones could even impinge a patient from getting off the tube. Okay, because the granuloma is so big. Okay, just think about it. Okay, I'm going to ask Tom here for help. Okay.
頭先講過咧就係咧，如果你擺咗條 tube 喺度啦，係咪？咁呢個位咧，佢會成日有機會會掂到個 tracheal wall 噶嘛，係咪啊 ？Single cannula 就冇所謂啦，咁你擺咗喺度，佢換都係成條換啫，係咪？咁亦都唔會一日換3、4次噶嘛，係咪？咁但係呢一個咧，因為有機會成日換咧，如果佢呢一度佢已經有嚿肉牙咁樣可能好細嚿嘅跌咗喺呢個位，佢再咁樣喺度即係出咗入咧成日，咁會點咧？呢度就會個肉牙就會越嚟越大咯。咁有機會咧，我哋見過啲 patient 咧個肉牙咧係大到咧，我哋叫一個 subglottic 嘅 granuloma 咧，佢大到直頭阻住佢透氣，所以佢甩唔到 trachea。因為一甩咗嘅話咧，嗰個肉牙就會阻住佢透氣。OK，咁所以呢個就係
即係 one of the problems with the double cannula tube. Okay, so be really, really careful when you remove the tracheostomy tube. Okay, don't try to remove it forcefully. Okay， 我試過見過啲 nurse 真係唔係 nurse 即係同啲 medical personnel 啦。掹嘅時候，明知見到佢都繼續咁樣掹出嚟，其實就係差唔多將成個 granuloma 扯甩得唔滯。OK， 咁係好痛嘅，你聽都痛啦，係咪？咁掹嘅時候更加痛啦。OK， 好 ，this is the second type, shiny. This is second brand, shiny tracheostomy tube. These are just a few variations. Okay, you can go to its website, the Medtronic one. See there are all kinds of tubes. Okay, so we have the cuffless, we have the cuffed, and then the cuff might have a fenestration or non-fenestration. So what does all these mean? This is another brand Traco. Okay, let me get through this first. A cupped tracheostomy tube, okay? That thing here, this balloon-like thing, okay? It's called a cup, okay? And some tracheostomy tubes have a cup, some don't. Okay, so what's the function of a cup? The cup is essentially an inflatable balloon. Okay, so the inflatable balloon, which can be inflated outside the tube. Okay, don't be so naive to think that it has to be inflated inside the tube. Okay, no. It usually, if you have a cupped tracheostomy tube like this one, okay, this is a Vortex one. That's a cup. This is the cup, right? Okay,
and the cup can be inflated with a syringe. Okay, so this is, let's put it on again. Okay, so if the patient has a cupped tracheostomy tube, so this is going to be outside the patient's body, and what you can do is use a syringe. Okay, and then you push air into it, and then the cup gets inflated. Okay, so what's the purpose of the cup? Just by looking at this, what does it tell you?
What's the purpose of having a cup? Or what is the purpose of having a cup inflated? Okay, the main thing is to prevent aspiration, okay? Or not to prevent, but to reduce aspiration of the saliva into the airway, okay? But this is not entirely correct, because if you have secretions right there, is the patient aspirating already? You know, from our point of view, it is, right? Okay, so a proper way to put it is that the cup, when inflated, it's to prevent the secretions getting into the airway. Okay, so that's the purpose of having a cup. And this inflation can be done either very conveniently using a syringe, or it can also be used. It can also be inflated using a cup manometer. Okay, because it will tell you exactly how much the pressure is, whether you're injecting too much air or not enough air into it. Okay, if you inflate too much, what's going to happen? 你想象下個吸係一個氣球，然之後個氣球喺呢個口裏邊，咁我不斷打咗啲氣入去個氣球裏邊嘅時候，如果打得太多會點啊？咁就會脹住啦，係咪啊？咁你個口就會覺得頂住啦。咁如果唔係個口，而家係講緊個 trachea 嘅時候咧，咁就有機會就會覺得頂住咯。咁但係 bear in mind that these patients a lot of times are not conscious, so they won't feel anything. Okay, but it could be possible that you overinflate, then you're compressing a lot on the tracheal wall. Okay, how about if it's underinflated? 如果我打咗啲，我即係小心啲啦，我淨係打2-3秒氣落去啦，咁又點咧？咁個吸就即係冇用咯，係咪啊？即係咁佢都係會照喺側邊線落去啦。Okay, so it's not going to serve its purpose. So that's why to do it properly, you want to have a cup manometer. Okay， 但係咧，我哋有一個即係戒避忌嘅就係咩咧？就係咧，如果你去到個 patient 嘅時候，佢個吸已經打着咗啦，係咪啊？譬如
好似佢咁啦。好啦，咁你又冇呢嚿嘢喺度喎，你又冇個吸嘅 manometer啦，你點可以知道你？
嗱，你譬如我哋假設我哋要做 assessment 嘅時候，我哋要 deflate 佢啦，一陣我會講點解啦，要 deflate 佢。deflate 完咗之後，你要 ensure 佢你攞走幾多，你就打翻幾多嘅話，即係好似冇人知道你做過 assessment 咁樣咧，點樣可以做到啊？就係唔做係咪？冇錯啦，就係抽。
譬如佢咁樣啦，咁咧你確保你啲 syringe 係0啦，然後咧做嘅時候你就抽啦，咁佢咪 deflate 咗咯，係咪 deflate 咗做完，你唔好咁傻仔喺度即係拎走佢啦，喺喐嘅時候咁就已經唔同啦嘛，係咪啊？咁咧你 keep 住啲 syringe 喺個吸嗰度，然後到你做完之後咧就打翻幾多咯 ，OK， 然後就拎翻咗啲 syringe。
跟住靜悄悄咁樣離開，就扮冇做過。OK， 咁咧 ，so that's a way to ensure that you're not injecting too much air or you're not injecting more air than how it was. Okay, and you're not injecting too little. Okay, but I would always advocate if you're gonna see a lot of patients on with the cup tracheostomy, just bring along the cup manometer. 貴你千零蚊嘅啫。OK， 好，呢、個又係啦，全啦可以係啦，我寫埋 screen 出嚟啦。OK， 好，咁咧so that's the cuff. Okay, so and the most important thing, when can the cuff be inflated, deflated? Ultimately, it's up to the doctor. Okay, it's up to the doctor. In some of our patients, we would recommend the cuff can be deflated. Okay, but I think that would be a very, very advanced thing. So let's put that aside. Just keep in your mind that whether the cuff can be inflated or deflated is up to the doctor's decision. Okay, and the second difference among tubes is that some of the tubes might have a fenestration. Okay, so fenestration is an opening at the arch. Okay, it can be a small opening like this one, or it can be a number of smaller openings. Okay, 好似一點點咁樣嘅。It's at the arch of the tracheostomy tube that would facilitate airflow through the glottis. Okay, imagine if you have a tube like the one that I passed around that has no fenestration. If the patient is exhaling, so the patient, I have some diagram to explain that later on. If the patient doesn't have a fenestrated tube, where is the air going to go when the patient exhales? Most of it is going to go through the tracheostomy tube, right? Because there's no opening. If the tube itself has an opening at the arch there, like this one, during exhalation, more air is going to go up through the glottis because air is going to pass through this fenestration, right? Okay, so essentially this fenestration, the main purpose of it is to facilitate speech. And so that's the main thing, okay? And a lot of times if you have a tube with a fenestrated tube, if you have a fenestrated tube, a lot of times it would not be cuffed. Okay, understand? So usually the usual combination would be non-fenestrated cuffed tube. Okay, which is the Portex one that I'm passing around, or a non-cuffed with a fenestration. Okay, because these two things kind of contradict each other. Okay, but as you can see from this diagram, that we have tubes that are fenestrated, yet it's cuffed. Okay, but it's not very common. And usually, if you have this combination, you can always put in an inner tube that is not fenestrated, so that it becomes. If you put this tube inside here, it's going to become a non-fenestrated cuffed tube. Okay, so you have to be really, really clear of what kind of tube are you dealing with when you see the patient. Okay, and make sure when you want the configuration of a fenestrated tube, don't be so stupid to put in a non-fenestrated tube inside a fenestrated tube. 你需要有個窿俾佢可以講嘢嘛，係咪啊？你擺咗條冇窿嘅喉喺入邊嘅時候，咁佢咪即係等於一條 non-fenestrated tube 咯。Okay, so always check to see what combination you're working with. Okay, and as I said, this could sometimes lead to granuloma. Okay, so it's not a must. Now, this would be a very common setting that we see. We approach a patient. This is how a tracheostomy would be like. Okay, a few things. The things that I've mentioned to you. What is this? This is just a tracheal mask. So if the patient is on a tracheostomy and the patient needs oxygen supplement, how is he or she going to get the supplement? Not through the nasal cannula, right? Okay. With patients who needs oxygen supplement, who doesn't have a tracheostomy, is going to get oxygen through the mouth hole, right, through the nasal cannula. But if you see a patient who has a tracheostomy and then getting a mouth hole, then you know something is wrong. Okay. Either the nurse is not awake or the patient is, having some anatomical anomaly. Okay. This connected to the O2, going to give patient oxygen. This is the tube itself. What is this? That's the. You got math. 有呢條嘢代表佢係有 cuff， 冇錯啦。個 cuff 而家係 inflate 住定係 deflate 住啊？脹嘅定係唔脹啊？都幾脹 脹咗同埋打仗嘅時候咧，個 cuff 呢個 cortex 咧就 more obvious 嘅。This is a shiny tube. It's not as obvious. Okay, so you can see how inflated the cuff is. Okay, and if you take it down, you can see that the patient has a tube. Sometimes you would go and read the label of what tube this is. Okay, so you have to be, this is called a LPC, so that's why it's a tube that has a cuff. Okay, and it has an inner cannula like this one, so it's a shiny tube, and the color of the tube will tell you whether it's a fenestrated or a non-fenestrated. Okay, but these are all different brands would have different bottle names. Okay, but essentially it's the same thing. Okay, so you have to know the things about whether it's a single cannula or a double cannula, whether it's a cuff tube, and whether the cuff is inflated or deflated. Third thing, whether the tube has a fenestration or not, and whether the fenestration is working or not. Okay, so 3 things: cannula, cuff, fenestration. Okay, the brand is to make it easier for you, but it's not essential. Okay, and one last thing that I didn't put here is the size. Okay, a lot of times you would see in the notes that what size of tube it is. It usually refers to the inner diameter. Okay, it might not be exactly. So if you see like a size 7.5 cortex, as you can see from the cuff there, it would say down 7.5. That tells you that the inner diameter is about 7.5 millimeters. Okay, but it's not exactly that conversion. But anyhow, if you have a size 8 tube, that's going to be bigger than a size 6. Okay, pediatrics they can put a size 4 tube. Okay, the smaller it is, the less negative effect it is going to have on the tracheal wall. Okay, imagine if you are really short and skinny lady, you have a small trachea and then you have a big tube. If you're a size 8 tube, what's going to happen? The tube is always going to rock against your trachea. Okay, and how are you going to feel? You're going to cough to death. Okay, unless you're dead. Okay, because if you have a tube that's always rocking your tracheal wall, you're going to keep coughing. Okay, so it's essential to get a right size of a tube in the patient. Okay, but that's always up to the ENT. But we would recommend as well, we would recommend a smaller tube because it might facilitate voicing. Okay, so apart from these common ones, okay, I'm going to pass all these around so you can take a look. Okay. Apart from the 2 common ones, we also have like a different variations, like those with a supraglottic suctioning channel, or what we call a talking tracheostomy tube. Okay, this is just to give you an idea that all these are out there. Okay, talking tracheostomy tube, it would allow a patient who is on ventilator, whose cuff cannot be deflated, to be able to talk relying on oxygen supply from the outside. Okay, but this is pretty advanced. A lot of our colleagues have never seen that as well. So just to give you an idea of what it is. Okay, again, let's pass this around. This is the talking tracheostomy tube. Okay, and the accessories, as I said, the tracheal mask, which is a way to give oxygen to the patient, or the decannulation button. Decannulation is just a fancy term of cuffering. Okay, cuffering the tracheostomy. Cuffering means that if the patient can be decannulated, that means the patient would be likely to be able to off the tracheostomy tube very, very soon. Okay? So an hour has passed and we're not even to the real topic yet, okay? I haven't even talked about speech and swallowing, but it's essential to know about what type of tracheostomy tube you're working with, okay? Because it would make a hell of a difference when you ask the patient to talk and when you ask the patient to swallow, okay? So always know what tube the patient has and always put it down clearly in your notes, okay? If you just say, patient has a tracheostomy tube, okay, and the patient did follow what? I'm going to fail you if you do that, okay? You have to write down precisely, maybe not what brand, but put down whether the patient has a cup tube or not, a non-cup tube, whether the cup was inflated or not, okay, whether the patient has a fenestrated tube when you did the assessment, okay, it's very important. And when we talk about our role, so you hear me say, you know, we sometimes do counseling, we sometimes help the patient wash the tracheostomy, we do suctioning as well. So what exactly is our role? Now, I found this very helpful. As I said, the guideline is very useful. This is an ACI guideline from Australia, and it puts down our role, okay? We assess, we treat swallowing problems, we assess communication ability, obviously, and we don't just do that, we provide effective communication system, okay? Let it be verbal or non-verbal. Okay, if the patient cannot establish verbal communication through, you know, with a tracheostomy with side tube, try AAC, okay, or writing or whatever, then you would be facilitating communication. And so cup deflation trials in conjunction with the team, as I said, we would sometimes do this, you know, in specific wards where the doctors trust us more. Advise on weaning and whether the patient is ready for decannulation, so whether the patient can have the tube removed. Okay, so I think this is a pretty big step for speech therapists because, you know, in the days when I was a student, we were just going to look at the tube and then stare at it and give the patient some blue dye and then ask the nurse to do suctioning, and then, oh, blue dye comes out, patient can't eat, oh, there's no blue dye, roll the patient to BFSS, perform the BFSS, that's all. Okay, but now I think we're more involved in whether the patient actually needs the tube, when can tube be removed, whether the cuff can be deflated or not. Okay, we have a lot more say. So it's empirical that you should understand all these as well, because without, you know, sufficient knowledge, you're going to be embarrassed. You know, I've had a colleague, well, I shouldn't say that because you know that it's a Queen Mary colleague, but I've had a colleague who puts in a non-fenestrate, who demands the patient family to go and get a fenestrated inner tube. Okay, the one who is holding the shiny, yeah, there. Okay, the patient has a shiny tracheostomy tube, but actually has a non-fenestrated outer tube. Okay, and then my colleague goes and try. Oh, the patient can't speak. Let's try a tube that has fenestration. Okay, so she goes, or not he or she, okay, whatever, goes and asks the family, please go and get a fenestrated tube. Okay, what's the problem? The problem is that the patient has a non-fenestrated outer tube. I don't care if you